So hello everyone. Today we are here to discuss another topic, which is the management of acute and chronic constipation, right? Okay. So let's try to understand how do we manage such kind of patient in that case. First of all, let's try to understand what is the definition and the classification in a small thing. It's a constipation that is basically infrequent or difficult passage of stool. It's as simple as that. So there is a Rome 4 criteria has been introduced where they are basically saying that less than 3 bowel movements per week. There is a straining, hard stool and sensation of the incomplete evacuation is basically known as a constipation. So we have acute and the chronic ones, right? So your acute one, when the scenario basically stays there for less than 3 weeks, but your chronic one, when the scenario basically stays there more than equals to 3 weeks, that is your chronic one. Okay, now let's try to understand what is the approach to the acute constipation is supposed to be. First of all, any patient comes to you with an acute constipation, always, this is the rule number one, try to rule out obstruction. So for that case, you do need to understand what is the history, examination and the imaging. If you do need to go for that, you must rule out the obstruction. So obviously in case of obstruction, the patient will obviously give you some obvious signs like there is a vomiting, there is a nausea, there is abdominal distension, and the patient will usually complain of obstipation in that case, right? So in the examination, you are able to get a distended abdomen, okay, and obviously you do need to go for the digital rectal examination where you are not able to find any stool staining, and there is a rectal hollowing as well. So in the imaging, it's always start with straight X-ray abdomen, right? They can give you some valuable clues regarding small and large intestinal obstruction. Okay, and also you can go for the USG, and the CT scan is also there. But you do need to understand there is some red flag signs, like there is a patient complains of sudden onset of weight loss, there is a bleeding, like either in a the the bleeding is supposed to be in a form of hematemesis in some time or in a form of a melena sometimes. So always do try to rule out the cancer in that cases. So obviously your initial management is supposed to start with a enema, and sometimes you can go with a suppository if there is a impaction is suspected, or if you are able to get impacted stool on a digital particle examination. Okay, you do need to address the underlying cause. So sometimes the patient may comes to you with some with a features of dehydration, or there may be incidence of the drug induced constipation in some cases. So you do need to acknowledge that as well. Okay, now let's try to understand what are the things that you do need to take the evaluation for the chronic constipation, like your detailed history and the physical examination. Okay, so like the duration, if there is any associated findings, weight loss and other things are there, whether the patient has recently undergone any kind of operations, right? So these are the detailed history we're supposed to take care of. Also the physical examination, do the part abdomen and detailed digital rectal examination. Look for the necessary findings. What are the necessary findings you do need to understand, like there is a rectal hollowing is there or not, any evidence of complication of constipation, like there is anal fissure, sometimes there is a piles, or there is a perectal abscess that may be present in some patients. You do need to take the note of that. Okay, and obviously if you are able to get any kind of a perectal mass, obviously do try to go for the colonoscopy. Okay, so in case of any other alarming features, you must go with the colonoscopy in that case. Obviously there are few clinical scenarios where you do need to go for the anorectal manometry or sometimes the colonic transit studies. Even there may be a need to go for the difficography, especially in refractory cases. Okay, now the basic management principles, right? So obviously there is a general uh, a lifestyle a suggestion that you must give to the patient. Okay, always try ask your patient to take the high fiber diet. Like brands are there, there is a fruits, vegetables and nuts. So the patient must take 20 to 30 grams of high fiber diet per day. Apart from that, the adequate fluid intake is supposed to be there, like around minimum 1.5 to 2 liter per day. If you are practicing in some humid areas, so in that case you do need to advise much more amount of the water. Also ask the patient to go for the a regular exercise, and the bowel training is supposed to be done. Okay, you always ask your patient to just try for the bowel movement at very early in the morning, or sometime you can also ask the patient to go for the bowel movement after 30 minutes of eating, because they can able to get the advantage of the gastrocolic reflex in that case. Okay, now let's try to understand the pharmacological management. Okay, so regarding the first line, there is a bulk forming agents. So this bulk forming agents, they can be either soluble one or they can be either insoluble one. Like the psyllium, isabgol, these are the soluble one, but your methyl cellulose is the insoluble one. So first of all, you need to understand how they basically work. They basically drag water from the surrounding structure or the tissue, and they will basically soften and make a bulk in the stool. So these are pretty much well tolerated, but except there is a some complication or the problem with gas bloating. Okay, that is the only thing that you do need to consider here. So then comes your stool softener, which are the emollient laxatives. Stool softener, right? So this stool softeners, emollient laxatives like the docusate sodium and the docusate calcium, they basically work by decreasing the surface tension in patient. So as a result of that, there is a decrease in the surface tension, and that will eventually allow water to enter into the substance of the stool. Okay, that will eventually a softening of the stool has been happening. Now they are typically used in case of painful defecation that has been associated with the external piles. There is a fissure in such cases. Okay. Apart from that, there is a second line. These are the osmotic laxatives like the peg, lactulose, and the sorbitol. These are there. So this osmotic laxatives, so you do not understand these osmotic laxatives. Like also there is a milk of magnesium. So as they basically an hyperosmolar agent, they basically drag water from the intestine, and that's how they basically work. Now regarding the milk of magnesium, you must avoid milk of magnesium in a patient with a congestive cardiac failure, chronic renal failure patient. Okay, but obviously apart from that, the PEG is there, polyethylene glycol, which is pretty much well tolerated. But also there is a lactulose and the sorbitol, because this lactulose sorbitol, they are not uh, because the lactulose and the sorbitol, they are not digested inside the intestine, that will eventually cause some flatulence and abdominal distension in the patient. Apart from that, there is a stimulant laxatives, which are the bisacodyl and the sena. These are the short. These are basically used for the short-term use, but they are eventually avoided in a patients with a elderly one, right? Elderly patients, you must avoid this stimulant laxatives like the bisacodyl. Then comes your secretagogues. So your secretagogues are the lubiprostone and the linaclotide. They are typically used for the IBS, like the constipation type of IBS. But obviously apart from that, there is a prokinetic drugs like the leuprolide or the procalupride. These are the 5-HT4 agonist, right? So these are the used for the constipation predominant IBS as well. Okay. Now, obviously, there is a special circumstances like the management in special situation, like elderly patient, as I have already mentioned. Avoid the stimulant one. Pregnancy is always safe to go for the osmotic agent or the bulk forming agent, but your opioid induced constipations are also there. Like avoid fiber alone in that case. You can use pamuras like the uh, naloxone or the methyl naltrexone in some patient as well. As I have already mentioned, the non-pharmacological and the surgical option, your biofeedback therapy, pelvic floor dyssynergias are very much effective. Surgical options typically for the refractory cases, subcolectomy, rectal anastomosis, transit time. Thank you.